Will the Committee of Supply please come to order? This section of the Committee of Supply will now resume consideration of estimates for the Department of Health, Seniors, and Long-Term Care. Questioning for this department will proceed in a global manner. The floor is now open for questions. Member for Roblin.
I just wanted to pick up where we left off at the end of our last time in this room. I believe I had asked about the intent behind the clause in the new collective agreement around not allowing nurses to work for an agency and hold positions in that same employment organization in the public system. I'm just wondering if you could expand on what the intent is and the intended effect of that provision.
Okay, the Honourable Minister. Honourable Minister of.
My critic for her patients. So what I can say as we get a bit more detail for the member base on that question is that the collective agreement that has been ratified in most regional health authorities as it pertains to agency, the question that the member is asking, nurses, we want nurses to have flexibility. We want nurses to have the opportunity to work wherever they are excited to work in healthcare. And so, for 7.5 years, there were no steps taken whatsoever by the previous government to ensure that there was a consistency of the quality and the approach of how agencies were being used, to ensure that the fiscal approach being taken was in the best interests of Manitobans, which is why we saw this marked trend in the increasing direction, which I think Manitobans have made very clear they'd like to see a more responsible fiscal approach when it comes to this particular area. Again, to be clear, I certainly want for nurses to be able to work in whatever capacities they're most excited to work. Being able to support that reality and making sure that reality reflects nurses working in the public aspect of the healthcare system means that there's a lot of work we have to do to repair damage that was done over 7.5 years. Addressing culture in healthcare, taking steps to make sure that nurses have increased wages. Government being at the table with the representatives, with unions, is something that our province hasn't seen. Previously, under the previous administration, nurses were denied a contract for 4 years. Healthcare workers had their wages frozen for, in some cases, almost 6 years. The impacts of that are devastating. We're seeing the impacts of that mistreatment in our healthcare system right now, to this day. It is going to take a tremendous amount of work and heavy lifting to repair that kind of damage. What does it say to a healthcare worker when a government disrespects them for 7.5 years? What does it say to a nurse when a government turns their back on the collective bargaining process for 4 years and says, we don't believe that you're deserving of the opportunity to have an agreement negotiated in your interests, in the interests of people who rely on our healthcare system? That does a lot of damage. And so our government has been committed to getting to the table with healthcare providers and experts across the province to make sure that they can trust that agreements will be negotiated in good faith. And so, your question about agencies, we want for nurses to be able to have agency in where they choose to work and how they choose to work. We also want to support them in having what they need to have a desire to work in the public healthcare system. We're seeing nurses consistently going into the float pool stream, which is something we've invested in enhancing. The float pool is it's very, very competitive actor in regards to challenging the narrative that agencies are the way to get more work-life balance. The float pool affords that. It affords increased remuneration, compensation rather. It allows for nurses to have a network of support, collegial support. It allows for them to contribute to benefits and pension, which we know agencies don't provide. And so The agreement allows for nurses to have choice. It also supports a consistent delivery of care and quality of who provides that care in a way we have not had previously. And so prioritizing nurses, what they've told us, that, in some cases, they're not even being made aware of shifts that are available. Nurses in the public system at certain sites aren't even being made aware of shifts that are available or the process that shifts get filled. And that's not okay. Having a process in place that provides that clarity is very important.
The member for Roblin.
So we talked about this issue a couple of times in question period last week and again in estimates around the use of agency nurses. And I raised some concerns, and actually the Free Press echoed those concerns in an editorial this morning. I'm happy to table it. I've got it if the minister wants to see it. The editorial board called this approach heavy-handed and coercive, and raised the very valid question, I think, of whether such a rigid policy that forces nurses to choose between working for an agency or working in the public system could backfire. So I'm just wondering if the minister can explain how forcing nurses to choose between working for an agency or working in the public system is going to improve the public system, and are they concerned that this is a gamble and that nurses may not make the choice that they are hoping they will make?
The Honourable Minister.
Thank you, Chair. I thank my critic for that question. So to be clear, the line in the agreement that pertains to that and what the member has referenced previously, what the member's tabled previously, isn't accurate. The language that the member's using in terms of forcing people to choose isn't accurate. And so what we're allowing are for nurses to have more choice, actually. And so more choice being that if they want to work up to full-time hours, if they want to work part-time and access a vehicle to do that, they can do that through the float pool. That will give them increased flexibility, increased compensation, increased benefit to their benefits. And you know what this structure allows for nurses to do and what it allows employers to have is what we've been hearing nurses say that they want. They want the opportunity to be able to pick up and have in the public system and to have an approach that doesn't deprioritize them being able to provide that care in that structure and that framework. And so, you know, it's important, again, that for many years, there was no consideration of how should agencies be operating in Manitoba. And now we're in a place where other jurisdictions look at our province and say, my goodness, you know, Manitoba, despite having a per capita demographic far less than, let's say, British Columbia, has a massive amount of agencies operating and really no consistency in terms of how that is rolled out, how those decisions are made, the quality that's being expected from these agencies. And we've heard very loudly and clearly that nurses and healthcare workers and providers and Manitobans want an approach that prioritizes patient care and safety, quality of care, fiscal responsibility, which will allow, and I think everybody said that they agree, the expenditures on agency nursing in this province is well beyond what it should be, and actions do need to be taken. I've heard that from healthcare workers and nurses alike. And so this structure will allow, and it recognizes that it's time to modernize the way that we approach scheduling in healthcare. It gives nurses the opportunity, again, to be able to pick up shifts where they would like to pick up shifts. It gives them a time frame for that work to be done, right? So we're not talking about tomorrow, we're talking about a year from now, this being in place. And it gives nurses time to decide what works best for them, not being forced to choose. Nurses, if they want to work in the public system and they want to work in the float pool, great. If they want to work in the public system and continue to work in agency, they can. This isn't forcing nurses to do anything any which way, but it is allowing nurses to have greater options, greater flexibility, potentially choose working in the float pool, which will offer them a great package in terms of their practice and work-life balance. And it allows the employer a process to make sure that nurses who do work in the public system are able to actually access opportunities to pick up shifts. What I've heard from folks is that there's a pattern of, in some cases, going to agency first and foremost, and nurses in the public system not having the opportunity to pick up shifts that they would like to pick up. And so this approach will allow for nurses in the float pool to pick up. It'll allow for nurses in the public system to pick up. It will allow for agency nurses to pick up. But what it does is it emphasizes having measures in place that support the strength of the public healthcare system. The system that the vast majority of Manitobans want us to move in a direction where it's strengthened again, not cut like it was for 7.5 years and deprioritized. I think that's a really important thing to think about and to factor in here is that, you know, it's important that we have actual process in place that prioritizes strengthening basic things like scheduling, which basic, but it can be pretty complex in the public healthcare system. And so this allows for an approach to be developed with healthcare leaders, with frontline staff, with human resources to ensure that there's consistency in the approach, and that we're prioritizing our investments, strengthening the public healthcare system, and at the same time, giving nurses the opportunity to have improved work-life balance and flexibility and choice.
The honourable member for Roblin.
Thank you. I don't believe I've misrepresented the words are pretty clear in the MNU document. A nurse cannot work for an agency and pick up shifts with the agency in the same EO where they hold a position. So that is forcing nurses to choose. Either you're going to work for the public system in this employment organization, or you can work for the agency, but you can't do both. And I understand that that might be something the union wants, but I don't know that that approach is going to serve the best interests of the healthcare system as a whole, because we know that one of the reasons nurses go to agencies is for flexibility. And the minister has talked about the float pool as a means of providing flexibility to nurses. But the only incentives in this agreement to draw nurses back from agencies to work in the float pool or elsewhere is if they're willing to work full-time hours. And I know the minister knows this, that there are a lot of nurses who don't want to work full-time and cannot work full-time. I talked to a nurse just last week who called that incentive hurtful and demoralizing. She's unable to work full-time hours, but she's been working all through the pandemic and feels that she's worked incredibly hard. And this incentive is not, she can't get the hours that she would need to achieve this incentive. So if she were working for an agency, that would be no motivation at all to leave the agency and come work for the public system. So I'm just wondering if the minister has anything up their sleeve to incentivize nurses who don't want to work full-time.
The honourable minister.
I appreciate the question from the member, and I appreciate her implication that maybe I'm a magician part-time, something up my sleeve. But what I will say is that nurses working part-time do have incentives. And so, you know, as the member can imagine, being a nurse in the healthcare system, previously under the previous government for 4 years, where their wages were frozen, part-time and full-time and casual nurses, all had their wages frozen by the previous government, who refused to get to the table and bargain in good faith. That has an impact. I would argue that that certainly affected the ability of nurses to have balance, probably forced nurses, to use language the member has used, forced nurses to pick up more shifts because their wages were frozen, because they didn't have the ability to negotiate for improved benefits, wages, et cetera. What this agreement does is it improves the wages of part-time nurses. It improves the benefits of part-time nurses. And it allows them the flexibility to pick up, if they choose, maybe not up to full-time, but if they do choose to pick up any additional shifts whatsoever, they will have increased compensation as a result of that. There are premiums involved for nurses who work, yes, part-time. And so it is, there are details that, you know, I'm happy to share here at committee that outline how this agreement does provide additional benefits for nurses working part-time, be it in the remuneration at a fundamental wage level year over year, be it their benefits being enhanced in a significant way, even for part-time folks, be it increased flexibility to pick up, if they so choose, and to be additionally compensated and contribute to their benefits and pension if they choose that. And so I do think it's important to acknowledge that I get the frustration of where many of these nurses who've reached out to the member, as she says, are coming from. I can't imagine how frustrating it must have been for years to have their wages frozen, to have their resources cut, to be forced out of, in some cases, careers they loved because they had a government who didn't respect them. What this agreement does is provide increased remuneration, improved benefits, increased flexibility and options for nurses to pick up within their capacity if they so choose. It also outlines an understanding, an agreement to work collectively to develop nurse-to-patient ratios that will improve the conditions of the work environment and improve the delivery of the quality of care for patients, which is something that we've heard nurses say that they want for a long time. Another step, even in terms of having that conversation that was never taken under the previous government. These are all steps in a direction that we've been hearing from nurses has been needed, has been desired rather for some time. And so, you know, I would hope that when that member is having conversations with folks, with nurses and others, that she has the breadth of the information available to her so that she can offer that, so that she can share that to folks who are reaching out. Certainly, I do think it's important that nurses have as much and all information actually as possible available to them. And, you know, I use this opportunity to provide that information and reassurance that there are incentives, be it premiums, wage increases, percentage increases, benefit increases, improvements to how they can have pensionable benefits, more work-life balance and flexibility available to them. And I think that all, in terms of a package, speaks to our commitment to working with nurses, not against them, like they experienced for 7.5 years under the previous administration.
The honourable member for Roblin.
Thank you. This is a very simple question about the float pool. Last time we were in here, the minister provided the names of lots of facilities where float pool shifts are available to nurses. I believe most of them were in the north. There were some in Interlake as well. I'm just wondering, are shifts available for float pool nurses in the WRHA and at HSC as well?
The honourable minister.
Thank you, Chair. I thank the member for that question. I just want to reemphasize that the agreement that has been ratified in most RHAs as of now provides more flexibility for nurses. It creates more opportunity for nurses to work where they would like to work. I think it's a really important thing to note that currently, if you are an agency nurse, you can't actually, I guess I shouldn't say that, I'll reword that. Currently, a nurse in Manitoba, let's say working in the public system, can't just pick up anywhere, right? This agreement will allow nurses that flexibility. It will allow nurses working in the public system to pick up where they would like to offer support. Could be you want to pick up and you want to work at your own site. Could be you have an interest in working at a different site. Could be you have an interest in working in a different region. It will allow nurses the flexibility to do just that. And in terms of incentives, because the member did ask about that, If you want to do that through the float pool, you have an additional incentive to do that. You'll have increased compensation premium. You'll have the ability to pick up whatever amount, a lot, a little, and have that contribute to your pension. This agreement actually gives nurses and creates more flexibility for them. It creates more options for nurses to be able to choose from, which is important because at this current time, nurses don't have that level of flexibility. It's important to also note, and just speaking toward, maybe I'll add a finer point on that as well. I do think it's really important for folks to recognize that being able to contribute to your pension, being able to contribute to your benefits does mean a lot to a lot of nurses. Not to everybody, right? To some folks, it's less of a priority than it is to others, but it is significant for a lot of nurses. And this agreement allows for nurses to pick up in ways, again, at a premium and also contribute to their benefits. And that is significant. You know, this agreement allows for nurses, because we take, you know, health and wellness seriously, it's enhancing their benefits package for nurses. You know, they deserve to have enhanced benefits. They work really hard. So there are benefits here and there are incentives here that do matter, that do make a difference. And again, being able to come to the table and show nurses that they have a government that is willing and wanting to do that and to hear them is important. I do think that, you know, Manitoba is also due for a modernization of the way that we approach staffing and scheduling in the province. And so that work, modernizing a system for nurses, is also really critical. And taking into account that we're going to keep doing this work. We're going to keep evolving what this looks like to benefit nurses and to first and foremost benefit patients. To the member's question about geographical needs, you know, certainly yes, there's the float pool is really noted in the north. It's noted in the north, Interlake, it's expanded to Southern and Prairie Mountain Health. We know that those are areas that have unique staffing challenges, unique staffing needs, and it's crucial that we support these regions and give them levers they can pull to address their staffing needs. The float pool has been an incredible tool for these regional health authorities to be able to staff and to staff in safe ways that ensure quality of care and consistency of care. That's something I've heard stories. I have heard stories from folks in rural and northern Manitoba who have had nurses assigned through an agency, and nurses showing up who have never practiced in that particular area of healthcare. I'm a psychiatric nurse. If somebody told me tomorrow to go and work in resus in an ER, I might listen. Nobody wants that. It takes a particular specific skill set, and we need to make sure that we have a confident sense of how nurses are being assigned to sites. And I've heard a number of incidents where those decisions and how they're being made aren't aligned with making sure that the quality of patient care is where it needs to be. So this agreement provides more flexibility. We're going to work with regional health authorities and nurses to make sure that the situations that I've heard of are mitigated and that patients can count on getting the quality of care that they deserve in the system.
The Honourable Member for Roblin.
Thank you. So we've talked about this issue in QP as well, but I wanted to bring it to the table here so that we could discuss it a little more thoroughly without the time constraints and the heckling and the political atmosphere that we get in there sometimes. It's around the safety issue for nurses, because we know that that's one of the things that prevented the tentative agreement from being ratified with the shared health nurses in particular at HSC. So just in terms of getting the lay of the land, can the minister tell me how many institutional safety officers are currently in place, specifically at HSC, but I'd be interested in the numbers for other sites as well, and how many are still being trained and expected to be brought online?
The Honourable Minister.
Thank you. We're going to work on getting that information for the member. That's a good question. I do want to make sure that I clarify my previous comments. And so we are going to continue to invest in enhancing the float pool. WRHA has significantly less of a need than rural and northern communities. We see that just based on the numbers. And so the priority, obviously, in making sure that areas of highest need have the supports that they need through the float pool. But we're going to continue to invest in enhancing the float pool, be it WRHA and at more sites across the province, most definitely. And as we see nurses continue to reach out to the float pool and join the team there, which is happening on a daily basis, we'll continue to do that. As I stated previously, we more than doubled the number of nurses in the float pool. We're onboarding a number of folks. A significant number of those folks are coming back to the public system from private, which is really good. I think that's a really, really good sign that folks feel confident and hopeful about working in the public system. And that's what we want. We want for people to have choice. And we also want for people to choose to support public health care because it's a fundamental Canadian value that we uphold. It's something that Manitobans depend on. Again, the vast majority of Manitobans count on that as being a place that they can access quality health care. You know, the member asks about safety and security at our sites and specifically around institutional safety officers. And I appreciate that she's raised that. I've said it previously, and I want to reassure the member that I wasn't trying to be cheeky or funny about the fact that when we came into government and I was being briefed on different issues, and I asked specifically about safety, because it is something that I was hearing, we continue to hear, that member continues to hear. I was literally shocked. I was jaw-dropped when I was told that there was no plan whatsoever outlined by the previous administration to have institutional safety officers at sites across the province. And you know, if it were that there had been a little bit of a plan or some work being done, I would state that. But there was no strategy in terms of how these officers were going to be trained, you know, when they would be coming online in the system. None of that had been detailed, which shocked me, given the concerns we've been hearing for years around safety and security. Part of how we were able to get institutional safety officers on site by the spring was by giving very clear direction that this needed to be done. That we have the tool of legislation in place. We have, which had been in place for at that point, well over 2 years, maybe 2.5 years, that had already been passed. And it was just a matter of receiving direction from the ministerial office to say, this is a priority. Institutional safety officers need to be trained in Manitoba. They need to be hired, and they need to be on site at HSC and other places across the province. Now, you know, when I have conversations during the listening tour, and I'll name Selkirk Mental Health Center as a good example. So we had a listening tour stop there. We had a huge turnout there. And I have a tremendous amount of respect for the security folks who work anywhere in the province. I have a personal historic relationship professionally with Selkirk Mental Health Center. You get to know these folks who show up every day to provide safety and security to patients and staff. They take their jobs very seriously. And it says a lot to folks when they know that legislation's been passed to enhance safety and security, but they saw no action taken for years. And the conversations I've had with folks at HSC and SMHC and other places was relief when they were told that this work is finally being done. Folks are going to be on site by the spring. That work is going to be ongoing. There's no, we're going to check the box and say our work here is done. That work is ongoing. They were relieved. And so being able to finally have institutional safety officers on site at HSC as one step of many parts of how we're going to continue to enhance safety and security was long overdue. But, you know, it's an important step that our government has taken alongside health leaders and folks in the front lines who have made very clear this is a priority. And we're going to continue to train ISOs. We're going to continue to educate ISOs as more information is brought forward in terms of how we can enhance their skill sets. And we're going to continue to make sure that across the province, safety and security is prioritized in our hospitals.
Member for Roblin?
Thank you. Just to reiterate my question, how many ISOs are currently working at the various sites, and how many are in training and expected to be online at some point soon?
The Honourable Minister?
A little premature here. I'm still getting a bit more information, but I will, I'll provide the member information that I do have available, and I may have some more information in this session to offer. And I appreciate the members' patience as I offer a lot of commentary, because I do think it's important. It's an opportunity for me to put this information on the record, and I do think it's valuable. These are issues that I take very seriously, and these are issues that Manitobans take very seriously. One of the things that I really appreciate about the way that we are approaching the Institutional Safety Officer Training Program is that it's also creating a number of jobs. And so the economic benefit of a program like this is that wherever these folks are going to be working and where they're being trained is also an opportunity for folks in the local area to access this training and opportunity. To me, that's pretty great, especially when we think about the importance of healthcare as a community of healthcare providers. Whatever role, whatever hat you're wearing in the healthcare system, you're part of that broader healthcare team. It's important for that broader healthcare team to look like the communities that are being served. And so when you have training opportunities like this, institutional safety officers, The approach that is being taken is to also support people having a chance at getting trained in this regard. Institutional safety officers are receiving the kind of training that includes de-escalation. It includes technical training around tools and equipment. It includes, culturally informed aspects of training as well. It's pretty comprehensive. And that is really advantageous for a lot of folks who, maybe want to broaden their skill sets beyond this as well, and making sure that we are taking an approach that creates good paying, stable jobs is key. It's a good economic approach and strategy as well. The training, the number around how many folks are in training right now might be a little tricky for me to provide. I'm going to try to get clarity on that, but we've got cohorts that are being trained regularly, and so those numbers may vary at any given time. But what I can share with the member right now, we've got 37 institutional safety officers at Health Sciences Centre, and that is of the 42 who will be there entirely when it's totally at complement. We have 4 at St. Boniface. They've been there now for several weeks. We've got 16 that graduated not long ago and will be at St. Boniface and Victoria General Hospital. We have a number of institutional safety officers that will be joining those folks right away. So I believe about 16 additional institutional safety officers will be joining that location in the coming weeks. And so again, we're training cohorts of institutional safety officers consistently, and we're rolling them out across the province. The member asked a question earlier in question period today that I think is an important one and speaks to, at the heart of it, I think, whether or not there's an openness or an opportunity to, if we see that there are needs that are arising in different areas, are we able to meet those needs? And I want to, reassure the member that the answer to that question is yes. That, there are sites across the province as we continue to work with our partners to make sure that safety and security is a priority, that we are also going to make sure that we can take steps that are appropriate to have enhanced safety and security measures. And so, like I said, the work in terms of safety and security across our hospitals and across the province in healthcare, there's no end point for us. It's a matter of being open to listening, working with leaders in this area, hearing what the needs are on a site-to-site basis in some cases, and developing an approach that makes good sense. And so there are a number of steps being taken in terms of addressing safety and security. HSC is a good example because in the last number of months, we've seen particular incidents of concern around safety and security really decrease because of measures that have been taken. Every report of compromised safety and security is taken very seriously, and we'll continue to adapt and take steps that continue to move us in a better direction.
Honourable member for Roblin.
Thank you. Continuing in the same vein, I just wanted to ask about the equipment that the ISOs have. I know initially when they first got on the job, there was a little bit of confusion about what equipment would or wouldn't be available to them, and I believe the minister ended up issuing a directive to get them specific tools. So what tools do ISOs have? We know they have pepper gel. What else do they have when they're on site?
The Honourable Minister.
I appreciate this question from the member. I would like to talk about tools in the fulsome sense of that language. Institutional safety officers are trained in a myriad of ways to deal with situations best addressed by institutional safety officers. So they are trained in de-escalation. They are trained in use of force, appropriate use of force. They are trained in how to appropriately subdue a person. They are trained in terms of cultural awareness. And I understand the questions around what tools they have in terms of, is it pepper gel or or is it a baton like in other sites? But I do think it's really important to understand that the conversation around safety and security does not begin and end with pepper gel and batons. That it is about increasing staffing resources on sites, at locations, to make sure that the reasons why we see increased pressures and tensions at certain locations is due to lack of resources. It is creating an environment in culture and healthcare where people, no matter who you are, can access a service and be met with dignity and respect, which I know healthcare workers show up every single day delivering care rooted in that. However, it's important that we equip people with the education and awareness and training to understand that people are very diverse and how to meet diverse needs when they arrive on site. And so the tools that institutional safety officers are equipped with to deal with escalated situations are folks who are presenting in a state of distress, which if you don't have the training, perhaps you won't be able to interpret distress for what it is. They're equipped with those tools. My direction was provided and given because of the outcome of what's the language? Thank you, the arbitrator's report. And healthcare leaders, frontline folks were waiting for that report. I was issuing a directive for institutional safety officers to carry pepper gel was a decision that I made because it was appropriate and necessary, and a tool that institutional safety officers having on their person allows them to access what they think and are trained, rather, to think is best in those circumstances. Another directive that I have given is for institutional safety officers to be fully trained on the scope of tools and equipment that could be available to them. Currently, they do have pepper gel, they do have handcuffs, they are trained and able to administer naloxone if needed. And so again, the scope of what institutional safety officers are trained with and trained for is to match the needs that we're seeing in terms of presentation to these settings. I also want to be clear, as I've stated previously, that this is a living process, meaning that should issues arise, we are going to continue to do the work of developing approaches that help keep people safe and secure. One initiative that I think is really important to acknowledge is Community Safety Host Program. I don't know if the member is aware of this program or not, but it's an initiative that has been very successful in sites like Mount Carmel Clinic, Millennial Library is a good example. This is a program that engages local community in roles of connecting with folks who are accessing these services in a good way, meets people where they're at, understands demographically the needs of folks who might be presenting. And it's a really, really effective program. And that's something that our government is actively working with partners, taking a good look at, alongside many, many other measures to see how we can strengthen safety and security in our healthcare system in a way that is dignified, in a way that puts people first, and in a way, when I've talked to healthcare workers and community and patients alike, they agree fundamentally is an approach that they want to see taken by government and by health leadership. It humanizes the conversation when we're talking about safety and security, which is really important.
The Honourable Member for Roblin.
Thank you. And I appreciate where the minister's coming from with this. I think, we always hope that situations can be de-escalated safely. Nonviolent crisis intervention is always the goal. But I don't know that it's always realistic. And I just want to quote this is from a CBC article, it's public. I didn't use this quote in QP today, but this is the scope of what's going on in the Crisis Response Center at HSC. And this is the words of the healthcare worker, not my words. Quote, "We are a 24/7 facility and we never close our doors. We have folks who are high on meth. We have folks who are psychotic, suicidal, homicidal, end quote. And I don't think in those situations that relying on ISOs to be able to safely de-escalate the situation without the use of a different kind of tool is always going to be realistic. Darlene Jackson called it verbal judo in the media and was very clear that it was insufficient to keep patients and staff safe. So we've got pepper gel, we've got handcuffs, we've got the ability to administer naloxone, which is critical, of course. But will the minister consider giving ISOs batons or tasers or other tools that they may need in situations which are hopefully very few and far between in order to keep patients and staff safe?
The Honourable Minister.
I thank the member for that question. Certainly, I do not purport to be an expert in security. That's not my background or my training, as much as I do a lot of reading. Pardon? And I'm a magician. However, I take this area and this issue very seriously. And so we do consult with and work with experts in this area in terms of the best approaches. And we will continue to work with experts in this area in terms of the best approaches. I do want to be very clear that, and I say this having been in situations on the front lines of healthcare as a nurse, and I've dealt with every single one of those situations. Folks who are actively under the influence of amphetamines, folks who are acutely psychotic, folks who are actively suicidal, folks who are acutely and actively homicidal. Been in every single one of those situations. Each of those situations are very nuanced, challenging, and in some of those situations, the most appropriate response, and in the case of the CRC, is police responding. And it's important to note that institutional safety officers and many other folks are being trained to have a scope that allows them to access many tools and utilize their skills in many situations and to appropriately respond in those situations. And we'll continue to learn as situations arise, how to better support institutional safety officers, how we can evolve the existing training, et cetera. This is, it's a brand new approach in Manitoba. Again, it's an approach that, had it been implemented 3 years ago, we would be 3 years further along in terms of what this needs to look like in Manitoba. Unfortunately, no action was taken under the previous government. We were able to get institutional safety officers on site in a very aggressive timeline. We're talking about 6 months. And that is a testament to what can happen when there's clear understanding of what our objectives are and folks are willing to work in collaboration to execute an objective. But it's also important to note that there are circumstances that can be really challenging and beyond the scope of institutional safety officers, despite their best efforts, beyond the scope of healthcare providers, despite their best efforts, and where you do need to call first responders who can provide the most appropriate response. And I recognize and I empathize and I think about and I care for deeply frontline healthcare workers, including those at CRC, who are navigating the impacts of a situation that obviously has affected, first and foremost, a family. And my heart is with that family that is navigating this loss. And what we do as a government and what we do as a healthcare system, what we need to do and what we are doing is listening to these frontline healthcare workers, working with folks to ensure that the approaches we take moving forward equip people with the tools and resources that they need. And so I do want to address the comment of verbal judo. That's a comment that it's not a comment that I would make or use. I certainly respect the perspective of Ms. Jackson, who made that remark, and I certainly appreciate her advocacy for increased safety and security on sites. I highly respect and value the skill set required to be a person who can effectively de-escalate escalated situations. And it is a unique skill set. It's something that our first responders, it's something that police officers are trained to do. It's something that we see police officers, RCMP, security officers, institutional safety officers, frontline healthcare professionals of all stripes utilize the skills of de-escalation. And it is a unique skill set. And I want to recognize that. I want to recognize that because it takes training, it takes commitment to utilizing that approach and the prioritization of the safety of others that makes it effective. And I just want to acknowledge we've got a number of first responders and healthcare providers who effectively use that skill on the front lines of healthcare and across the province every day, and I really do respect and admire that.
The honourable member for Roblin.
Thank you. I want to switch gears and ask about the status of request for supply arrangements or request for service agreements. I've seen always the acronym RFSA, but I've seen it to mean two different things, but I think the minister and the staff probably know what I'm referring to. The RFSAs that were signed under the Diagnostic and Surgical Recovery Task Force, I'd like to ask the minister how many of those have been renewed or re-signed for the 2024 fiscal year.
The Honorable Minister.
Thank you, Chair. I just want to clarify some information I gave the member and put on the record that was incorrect. So St. Boniface actually has 10 institutional safety officers on site. I think I had reported 4. Yeah, okay, so glad to correct that. We we're working toward having well over 100 institutional safety officers across the province. And as I stated, this is ongoing work. We're constantly evaluating and assessing where the needs are and what the opportunities to enhance that safety and security provision need to look like in the province. To that point, I do want to share, I talked a bit about this not only being an important step that we're taking in terms of safety and security at particular sites, but also an important economic opportunity. It's creating a number of jobs across the province. And there's an effort being made specifically in Portage la Prairie, which I think the member would be interested in, around having a partnership with the Portage la Prairie, so CSOs that exist currently or who we brought on board, but partnering with surrounding First Nations communities who have First Nations safety officers. And so working together to ensure access to this opportunity in terms of training and job opportunities as well. And, I touched on previously the importance of representation in these roles anywhere in healthcare, the importance of representation everywhere in healthcare. And representation at the heart of it also speaks to safety and security in our healthcare system. We know that systemic discrimination, systemic racism in healthcare is real. We know it exists in systems and that it hurts people. We also know that for some folks in some communities, being able to access healthcare and see somebody right out of the gate that looks like you and maybe has a shared life experience or understands your experience can bring down that anxiety and create a sense of safety and security for people. And so having folks who are in the role of institutional safety officers responsible for enhanced safety and security of patients and staff alike reflect back to Manitobans what they look like is one step. Being intentional about that is one way that we can improve safety and security fundamentally. And that goes for, all roles across the healthcare system. And so we've had a number of really meaningful conversations and really meaningful dialogue with First Nations communities and governments about how do we work together to support healthcare being a place where no matter who you are, you feel safe, secure, and you can access care that inherently meets your needs as a person. And so this work, this effort to have a partnership that would see surrounding communities also have access to this opportunity is really important. It's important to the safety and security of healthcare. It's important economically. It's important in terms of representation in healthcare. And again, when we talk about safety and security, it's a broader conversation that I welcome folks into so that we're applying not such a narrow lens to what that means for Manitobans. So I just wanted to share that bit of information with the member and make sure that she had those details as well. And I also, as she's well aware, if she's got questions beyond estimates, she can reach out anytime, and I'm happy to have that conversation with her. In terms of her previous question, I'm just getting a bit more detail, and I should be able to answer that shortly.
The Honourable Member for Roblin.
Okay, so while we're waiting for information about the RFSAs, that was in my previous question, I would also like to know how many procedures have been performed as a result of those RFSAs so far in fiscal year 2024-25. I realize that's only just under 2 months, so I don't know how much information is available, but I would be very interested to know.
The Honourable Minister.
Thank you, Chair. I thank the member for that question. I want to start by providing a bit of clarity as to the workings of the Diagnostic and Surgical Recovery Task Force that I have to say, coming into this role, it was incredibly difficult to make sense of what was going on with that task force. Again, another big old surprise for me after being sworn in was just how little clarity, line of sight existed into what was going on and how decisions were being made with that task force. Consistently, I would ask people all kinds of questions about how decisions were being made, and consistently nobody seemed to have a line of sight, which is really concerning. That's been publicly reported. You think that a structure that had a budget that significant would have increased measures of accountability. They did not. I heard from chief medical officers, I heard from health leaders across the province that nobody had a line of sight as to how decisions were being made, but everybody had concerns about dollar amounts like $7.6 million being spent on annual salaries in less than 2 years. Everybody had concerns with, in some cases, many cases, spending up to 7 times per surgery what would be spent here in Manitoba. And to the point where chief medical officers of health signed an open letter, finally calling for what was meant to be, my understanding, our understanding, to be a temporary task force to be concluded because of how disruptive it was and the lack of transparency and insight into how decisions were being made. I mean, even folks who access care beyond our borders via the task force made comments calling the approach to the task force and the spending lunacy, outrageous, and so they were embarrassed that that amount of money was being sent, almost $40 million out of province, that salaries, people were being compensated exorbitant amounts of money on that task force with no accountability whatsoever, none. And so the decision to invest in the public system, improve our capacity here in Manitoba, that is not a novel idea. Investing in improving capacity in your own healthcare system in your own province, you would think would be a fundamental value and approach that is well understood, but we saw the opposite of that for 7.5 years. We saw cuts to the public healthcare system. We saw lack of capacity in the healthcare system intentionally. We saw disorganization and chaos caused intentionally by the previous government. And what we've been able to do in our short months as a new administration is invest in improving capacity right here in Manitoba. Take those millions of dollars that would have been sent to San Diego, North Dakota, Cleveland, wherever, and invest them in establishing the province's first ever spine program right here in Manitoba. That's a massive step in the right direction that I know Manitobans are thrilled about. They'll finally be able to receive care in Manitoba for spine health issues. It'll also take pressure off our emergency departments. The other thing that we're doing is eliminating what some folks, some experts have called a shoebox approach to who it is that maintains lists in terms of patient care, and centralizing the way in which folks are organized for surgeries. I see the member for Interlake Gimli maybe is confused as to why I said shoebox approach. I'll explain that quite literally there are folks who they keep a hold of their own lists as surgeons, versus the list being more centralized and allowing for Manitobans to be slated for surgeries in a way that prioritizes them being slated for surgeries and getting that care in a timely manner. And so all of this work is being done and invested in the public system to allow for better transparency, to allow for Manitobans to get the care that they need. And we're seeing the benefits of that. We're seeing folks who have been waiting for, in some cases, 3 years, 2.5 years for surgeries, finally get those surgeries. None of that was addressed by the previous approach, which is unfortunate. If a different approach had been taken, those folks would have gotten timely care in Manitoba.
Member for Roblin?
Thank you. That is a lot of context. I will reiterate my question. I'm just going to put out there the information that I'm looking for to make it easy for your staff. I'd like to know what RFSAs are in place, with whom, for what services, and how many services they'll be providing.
The Honorable Minister.
Thank you, Chair. And thank you to the member for that question. I'll provide some information now in terms of the RFSAs. And I do want to note that, again, the Diagnostic and Surgical Recovery Task Force was always articulated to be temporary, never meant to be permanent. And I don't think the members ever disputed that. Meant to be a short-term structure. And I do reflect on the fact that, you know, I wonder about if almost $8 million hadn't been spent on exorbitant, outlandish salaries, how much more of a dent could have been made during that time in addressing wait lists. It's incredible that you can spend almost $40 million outside of the country for care and still not have addressed a wait list, many wait lists. You know, the fact that we have folks who were waiting, had been waiting up until I talked to folks recently, the duration of the existence of the task force, their wait lists were never addressed. They had no approach to having a streamlined approach to how their information was being dealt with. You know, folks could have had a spinal program in place years prior. You know, that is something to reflect on, definitely. And investing in capacity in the public system is a priority that Manitobans have made very clear to us they want to see executed beyond the spine program in many other ways as well. And we're seeing them. We're seeing volumes in the system increase. In terms of the RFSAs, I can tell that member, you know, that the contracts with the RFSAs, majority of them were ongoing. And so the ones that were not were due to capacity being enhanced in the public system for the most part. So Assiniboine Clinic, Winnipeg Clinic, Manitoba Clinic had contracts for cystoscopies, endoscopies, and Selkirk, Victoria, and St. Boniface Hospital all have improved and increased capacity in the system to deliver that care, to manage those necessary volumes, which is great. Men's Health Clinic is one provider where cystoscopies were shifted because they do such a significant amount of urology-focused care. And I'll just kind of run the list for the members so that she has a better sense of what I'm talking about. I apologize in advance for the mispronunciation of some of these words, but we've got cystoscopies, vasectomies, radical, inguinal, orchiectomy. I can spell that for you if you'd like.
I'll wait for answer.
All right. We've got orchiopexy, microscopic rather, varicocelectomy, hydrocelectomy, spermatocelectomy, Nesbit. He's not house. Is Greg in the room? Sorry. Nesbit, plication, circumcision, green light, TERP. How do I? Oh, thank you. Epidemectomy, cystoscopy, biopsy, and fulguration, cystoscopy and urethral dilation, excision, genital lesion, dorsal slit, frenulectomy, TURBT, I'm just terped, Foley catheter insertion. So that's the extent for Men's Health Clinic. So you can see it's heavy urology focused, right? Moving on to the other RFSAs. So the rest were continued at Visions, at Western, at Maples, at Cardio 1. And Visions are responsible for cataracts, Western for cataracts, and Peds Dental, and gynecological procedures. Maples is doing spine, that's right, shoulders and knees, so ortho, joints. And cardio 1 is echo.
The member's time is expired.
Oh, geez.
The honorable member for Roblin.
I would invite the minister to finish their response.
A minute. I'm just going to pull.
The Honourable Minister.
Thank you, Chair, and I thank the member for that question. Just want to provide a bit more clarity, and I appreciate her patience. I was getting a bit more information for her. So one other RFSA was with Cancer Care, and that was specific to prostate cytoscopes. That's technically not ongoing because it was made base. So you wouldn't see it as an existing RFSA because it's now part of the fundamental program. So we just enhanced their capacity permanently there. And as I said previously, you know, where we're able to invest in enhancing capacity and volume in the public system, because that's attached to resources as well, right? Staffing opportunities, et cetera, and having consistency there, we're doing that. I'd like to give a bit of an example of the value in terms of investing locally in our own province. So for every surgery, for every, let's say, hip or knee surgery done in Samford, we could have done 7 of those here in Manitoba. Same Samford, same with the spine surgeries. We could have done for every 1 done out of the country, we could have done 10 in Manitoba. When I think about the exorbitant salaries paid, you know, we have a salary for an IT lead that was paid, let's just call it $567,000. And, you know, for that, we could have had over 100 Manitobans get a hip or knee surgery here in Manitoba. We have folks who are making, you know, $200,000 in executive assistant roles. 38 Manitobans, 36 Manitobans could have had their surgeries done in Manitoba with that investment. Even more Manitobans if you had it done in Southern Health, because they have really, if you've been out that way, have figured out a really great way to do ortho surgeries as day surgeries. They've got a really great setup in the Southern Health region in this regard. And the fascinating thing in conversation with the leaders of that region was that they've been eager to work with government to enhance ortho capacity, but under the previous government, nobody had bothered to ask. Nobody had bothered to reach out and work with them and say, hey, you figured something out here where you're delivering this care in a way that really does meet people's needs. And instead of observing that and working with them to enhance capacity in Manitoba, very close to an urban setting, nobody would work with them from government. And so, you know, what we're doing is recognizing that Manitobans want a government that is fiscally responsible. We came into office, met with a $1.6 billion deficit, and Manitobans have given us a mandate to be responsible with their public dollars and to invest their resources wisely. And we're doing that by enhancing capacity in our public healthcare system and working with our partners, at Western Maples, Cardio One, Visions, you know, Cancer Care, et cetera, to make sure Manitobans can get access to the services that they need. And we'll continue to do that work to the benefit of Manitobans. So again, I can't emphasize it enough. I think everybody agrees, Manitobans have certainly made clear that it is absolutely outrageous that we were spending 7 and 10 times the amount of money to send people away from home for care that we could have built capacity around for years here in our own province. And it's been really wonderful working with partners across the province to enhance access to care and to make sure that we're moving in a direction where we're meaningfully not only addressing the waits that the task force did not eliminate or the backlogs they didn't eliminate, but also enhancing the opportunity Manitobans have to get the care that they need in their own communities. And we'll keep doing that work with folks across the system.
The Honourable Member for Roblin.
Thank you. I'd like to cede the floor to our colleague from Tyndall Park, who's been waiting patiently.
The honourable member for Tyndall Park.
Thank you, Chairperson, and I'd like to thank my colleague from Roblin for allowing me a little bit of time here this afternoon. Can the minister provide a specific update as to how many of the Auditor General's recommendations related to the Protection for Persons in Care Office have been implemented to date?
The Honorable Minister.
Thank you, Chair, and I thank the member for Tyndall Park for the question. I know that the member has a particular interest in this area. She's asked about it in QP previously, and I'm happy to provide a bit more clarity. So the member asked about the 12 recommendations. I can advise the member that 11 of the 12 have been completed. The one outstanding recommendation is number 8, which the target date of completion is this coming month, so June. And that's the recommendation that the PPCO implement a risk prioritization process for investigations and document it in their policy manual. So that is almost completed. What I do want to also touch on is the incredible amount of work that has gone into clearing that backlog. Folks have, understandably, importantly, they took the concerns brought forward very seriously. And, it's the report was horrifying, quite frankly. Some of what was in that report really, really horrifying. And the impact on families, obviously traumatic for some families. And so the work that the department has undertaken to rectify the outstanding investigations and alleviate concerns around that work being done, I really want to commend them for that. Folks have put in a tremendous amount of necessary effort to address that backlog, and also to ensure that moving forward, there's an approach that doesn't see that be repeated in Manitoba. The member for Tyndall Park is well aware that there is additional work being done beyond that to provide recommendations on what the path forward looks like. And I think that that's a really important conversation, because we know that many families and seniors are counting on hearing that feedback. They want clarity around what next steps are going to look like in Manitoba. I know the member has advocated for years about an independent seniors advocate. That will be established in Manitoba. Our government is going to make that happen. But there's even a more broad, bigger conversation around not only the advocate, but also safety, security, protection of seniors. What are the options that are available to us based on what we've learned from the challenges and the failings under the previous government to address concerns that were brought forward in terms of investigations not being completed in a timely way, lack of transparency and communication with families, lack of accountability to the process, all of that. There are a lot of pieces in this that we are doing the work with experts to address long-term. So short-term, being able to reassure the member and other folks across the province that these recommendations were taken very seriously. They're nearly completed. There's one last piece that needs to be done and will be next month. I'm always happy to have a conversation with the member about this work and to provide clarity. I know that she's got good relationships in community and she's talking to folks all the time about this particular issue and others. And I do want for the member to be able to go out in community and provide up-to-date information as folks need it. So where I can, beyond this committee, I'm always happy to provide that insight for the member. And I also want to put on the record that the approach that will be taken under our government in terms of next steps will be informed by community, it will be informed by experts. And again, as I've said about previous issues in this committee, there's no end point in terms of if we do these things, the work is done. The work will be ongoing. It's really fundamentally important to me and to our team and to our government that we keep an open mind and that we're a listening government, so that as new ideas, maybe even novel concepts are brought forward, that we have the ability and the flexibility to incorporate that into our approach. So I would ask that member and encourage that member, if she ever has other ideas or she's hearing things in community that she thinks would really be helpful and useful, we want to work with her and with anybody whose priority is making sure that seniors are protected, have access to the services and care that they need, and that they are aware of the work that's being done. Because I think so often some of the anxiety that people...
The hour being 5 o'clock, committee rise.
Thanks.